Hello and welcome everyone. Welcome to session 4 of the Tisch College webinar series. We have two really excellent panels today with really phenomenal panelists. I am going to begin with a very short time for pause to follow up on the mindfulness activities and presentations that we've had over the past couple of weeks. So we're going to begin by, I'll remind you of what we looked at during the first session, the stop practice, which is this stopping and pausing to collect yourself, taking a conscious breath, observing your thoughts, feelings, and your surround, and noticing how you can be in this situation without being ruled by it, and then proceeding with intentionality. And so this is a practice, a mindfulness practice that we can bring into our daily lives, given all the stress that we are experiencing in this time of multiple pandemics. Just having the tools to be able to draw on to address some of the stress can be really powerful. So this is a very short exercise, and we'll take just 1 minute before we move to the panel. So research shows that when you breathe in, that your heart rate speeds up, and when you breathe out and slow, long exhales, that your heart rate slows down. And it's a quick way to relax, to calm your nervous system. So by lengthening your exhales, so that no matter where you are, where you're in situations of great stress, just tapping into the power of your breath can trigger your relaxation response. So in 1 minute, we'll try a very short practice. It's called the 4-4-8. So it's breathing in, 2, 3, 4, hold, 2, 3, 4, and then a long exhale, 1, 2, 3, 4, 5, 6, 7, 8. So I'm going to hit the chime, and I'll invite each of you to just take a couple of rounds of the 4-4-8 and just long exhale. And then we'll move into introductions into the panel. So I'll sound the bell, and this will be in just about 30 seconds, actually. So we'll move into our panels, and in between the two panels that we have today, we'll take a moment for some reflection, for another time for pause, very brief, to invite each of you to try this out again, and then a time to respond to a reflection question. But without any more delay, we'll move into our panel. So the first panel is of this session called Dispelling COVID-19 Misinformation with Public Health Science, Epidemiology, and Digital Ethics. The first panel is we have experts in the field of public health and epidemiology who are going to share their work and their perspectives. So we start with Dr. Laura Corlin, and I want to just let you all know that we'll go through these slides quickly, but all of this information will be part of the recording, and it's also on the Canvas site for students to access. So Dr. Laura Corlin is an assistant professor in public health and community medicine at Tufts, and she is a Tufts alum. Dr. Abby Schiff just finished her PhD program at Harvard Medical School. She's also an MD, and she is the leader of and writer for the medical student COVID-19 curriculum. So she'll be talking with us about that today. And then Dr. Tom Stopka is also associate professor in the Department of Public Health and Community Medicine at Tufts. And he and Dr. Corlin are collaborating on a project related to COVID-19. And then we have our wonderful moderator, Alejandro Baez, who is a rising senior, and he is a community health and clinical psychology major. So thank you so much to all of the panelists.
Okay, hello, I'm unmuted. My name is Alejandro Baez. I'm the moderator for this first session. So the way it's going to work is that this panel discussion will be split into two sections with 7 incredible panelists. And before we begin the topic discussion of dispelling COVID-19 misinformation, I want to start off by inviting each panelist to share their pronouns and a fun fact. And I can get the ball rolling here. So again, my name is Alejandro. I use the he, series pronouns, and a fun fact is that this summer, I've been getting really into gardening. So I have my little pot here. I'm gonna put an aloe vera. Yeah, so I guess that I can pass the torch on to Abby if you're comfortable.
Great. Yeah, so my name is Abby, and you just heard a little more about me. I'm entering my final year of an MD-PhD dual degree. And so my pronouns are she, her, and hers. And a fun fact about me is that I studied art history in Paris for a year, actually before starting college.
Okay. Oh, that's really cool. Yeah. Laura, can you go next?
Sure. Hi, everybody. My name is Laura Corlin. I really appreciate you all being here today. I use the she, her pronouns. And a fun fact is that I'm from Colorado and I love to ski.
All right, thank you. Tom, can you go next?
Sure. Hi, everyone. It's a pleasure to be here. I'm Tom Stopka, he, him, his. And fun fact, I'm an infectious disease epidemiologist that likes to practice social distancing sports. So that includes fishing and golf whenever I can get out. I'm a husband and father of 3, 21, 17, and 14-year-olds. So sometimes the opportunities are slim.
All right, thank you all for sharing. And I guess we can go into the first round of discussion questions. So, and we can go in the order that we just went in for consistency purposes. So starting with Abby, can you please tell us a bit about your work, especially in relation to dispelling COVID-19 misinformation? We'd also love to hear a bit about why you've chosen to engage in this work.
Great. So I have a few slides to share about the COVID-19 curriculum. So I'll just get those up. And I can just talk a little bit about that. So as you all remember, in mid-March, as things were ramping up, I found myself in the interesting position of having finished a PhD looking at the interaction of viruses and the immune system in the lung. And a lot of my friends and family started asking me questions about what they should do, what information they should trust, and whether they should be going to social gatherings, things like that. And then also as a medical student, the patients I was working with and even the doctors I was working with were also asking me questions. And a lot of my colleagues also were trying to sift through all the literature and figure out what to trust. And so we decided that instead of just sort of working on our own, it would make sense for us to come together and make a resource that would actually be usable by, we thought, the wider medical student community, but it ended up going beyond that. So on March 14th, we learned that all medical students would not be able to be in the clinic anymore. And so on March 15th, there were a bunch of Zoom calls that got set up amongst medical students of all different years at Harvard Medical School. And one of the projects that came out of this was putting together a medical student written and reviewed, but also faculty reviewed resource to try to cover various topics related to COVID-19. So on March 15th, we conceived of the project. We assembled 4 modules covering basic science, epidemiology, training for potential clinical roles, and communicating information. And with a team of, at first, about 30 to 40 medical students, and then expanding to 75 medical students, we wrote over 80 pages of curriculum material. We peer reviewed it and then had faculty review by experts, at least 2 experts for each of these chapters. And then on March 20th, just during that first week when many institutions had shut down, we posted this freely available content. And I think in a time when there really weren't that many resources that were collating information and had their sources cited, and also talked about sort of the how to look at different types of literature, many people looked at it, and we've actually kept it up. We've had weekly updates since then. We've expanded it to 8 chapters. We've had 75 writers from multiple countries and institutions. We've had people sign our guest book from 110 different countries. And this curriculum, which includes things like questions for credit and ideas for essay questions and other sort of ways for people to measure their learning, has actually been used for credit in 30 medical schools, including Tufts and Harvard Medical School. So, I mean, this is really by students for students, but it's also been used by undergraduates, high school students, people at different levels. So I would encourage you to check it out at this link, curriculum at covidstudentresponse.org. So some of the topics covered include basic science, epidemiology, health disparities, policy changes, and socioeconomic effects in the US, mental health, communicating information, training for potential clinical roles, global innovation and collaboration, and medical ethics in relation to COVID-19. So I encourage you to check it out if you feel like it. Each of these sections also has a short 1-page summary. So if you want to have a quicker look, that's also possible. Offshoots from this, for example, we were asked by Zell to put together a visual review of COVID-19, which is include things the course, life cycle of the virus, and immune response. But the goal here really is just to take information from various sources and communicate it to the public in a time where many people have been, not sure what to believe and just have been really about this and all over the world. So I just wanted to highlight a few challenges in science communication during a pandemic. So one issue is providing accurate and up-to-date information. And as medical students, my colleagues and I were able to access and understand medical and scientific information. And then unlike our more busy clinical colleagues who were seeing patients during this time, we have had the time to collate it and be able to communicate it to the public. So it's been a challenge to sift through the available data. I mean, the volume of literature that's been coming out recently on COVID-19 has been quite impressive, and much of it is not that rigorous, unfortunately. So, having a bunch of people working together to figure out which data is the most reliable has been important. It's also been important to provide context for that information and tools to share the information with others. And then another challenge has just been that the climate has been so politicized, especially in the United States, whether it's issues about mask wearing or about, what is going on with, spreading the virus through stool or through touching things. A lot of these things have been areas where the data goes in one direction and then it might go in another direction. And then people who are less familiar with the way that the scientific process goes might be confused by the fact that the consensus has been shifting. So it's been important to communicate the level of evidence available, which is often not that high when people are first learning about a particular disease. And then also communicating that, the consensus develops over time with repeated studies as they get better and better. And so our understanding may shift. And so it doesn't mean not to trust the experts, but it does mean that sometimes the recommendations may change. And then also the importance of incorporating new insights into practice. So for example, there was a lot of buzz about hydroxychloroquine early on in the epidemic, and then many studies have come out more recently showing that it actually does not provide a benefit and may in fact cause more harm because of side effects. So, understanding that trajectory is actually not that unusual when people do clinical studies, but this has been really in the spotlight, and so it's been important to communicate that.
Yeah, thank you. Yeah, I've also, I want to note that I have seen that resource in circulation around, so it's been really amazing to look at. And again, like highlighting the point that this not only is important to get accurate information, but just linking that to mitigating harm in the long term. Yeah, thank you. Laura, same question. So can you please tell us about your work in relation to misinformation? And we'd also love to hear about why you've chosen to engage in this work.
Thank you very much. And thanks, Abby. It was really interesting to hear what you had to say about what medical students are doing. It seems like a very important initiative. I'm an environmental epidemiologist. I'm very interested in how the environment affects human health. It's a really fun field to work in. It's at the intersection of public health, environmental science, environmental engineering. As a triple jumbo with degrees from multiple schools at Tufts, it's kind of fun to get to use all the different disciplinary training I've had over the years here at Tufts. Before COVID, I focused primarily on how air pollution and water quality affect people's chronic health outcomes. For example, I've looked a lot at cardiovascular disease and cardiometabolic disease progression over the years. And in the COVID era, I've now had the opportunity to work with my co-panelists, Tom Stopka and many others, to think about how environmental determinants like air pollution and meteorological factors affect COVID transmission and severity, which has been, it's really nice to be able to apply some of the same skills in this new and important area, and to get to work with new colleagues who have expertise in infectious disease. So first, just a bit of background about why we care about environmental factors in relation to COVID. The environmental factors will not be the primary risk factors, but they are potentially still important. Many people have speculated that air quality and meteorological factors might impact either or both of transmission and severity. And if these factors are important to transmission or COVID outcomes, then we have opportunities to improve our surveillance systems or to figure out ways to predict and prevent disease spread and maybe to intervene more effectively. So it's an important area because it's something that we can modify, which is great. So what do we already know? Why was this an area that people were so interested in? There's 5 major ideas here. First, we know that environmental factors tend to affect pathogen survival. So for example, many viruses can only survive for a reasonable length of time under certain temperature conditions or certain humidity conditions. We also know that temporal, spatial, and social patterns in host behavior strongly influence disease transmission. And that's one of the reasons that we're all physical distancing and wearing masks and all that is very important. We know that air pollution and meteorological factors affect the incidence and severity of other respiratory pathogens, including other coronaviruses. Fourth, we know that exposure to air pollution is associated with a number of adverse health conditions, including things like heart disease that make people more at risk of having severe COVID if they do contract the virus. And then finally, we know that there are deep environmental injustices, often as a result of structural racism, sexism, and some of these very important issues that many of you are learning and doing something about, which is important. But in terms of who is exposed to air pollution or heat waves or other problematic environmental conditions, and these environmental injustices are strongly associated with health disparities. And so we're seeing that now with COVID as well. So understanding these different ideas has led us to several hypotheses. One is that poor air quality is associated with worse COVID, exposure to poor air quality is associated with worse COVID outcomes, independent of other factors that may be common causes of both air quality and COVID outcomes. So for example, a lot of the initial work saw that in dense urban areas where air quality tends to be the worst, that's also where you have most COVID cases, but that's also because that's where more people are concentrated. And so it's sort of hard to disentangle those different factors, but we're trying to analytically do that. Then the second hypothesis that we're really interested in is whether COVID transmission demonstrates seasonality, accounting for differences in pandemic control policies and movement patterns and other host behaviors, which is challenging. And again, there's been some initial work in this area, but there's challenges in terms of data quality and data availability that make this really hard, and we'll discuss in a minute here. And then the third hypothesis that we're very interested in is the idea that COVID disparities are at least partially due to disparities in exposure to adverse environmental conditions. And so, as I've suggested, our team and many others worldwide have been thinking about these issues now for a few months. And while a lot of work has already been done in this area, most of what's been published or pre-printed has had substantial limitations. And I think Abby suggested some of the reasons why. But within the environmental health space, these limitations, really just arise, I think, because people have been pressed to find answers really quickly, and people are doing their best with limited information. But it's really hard to study the effects of environmental exposures on health without individual level data. And most of the data that we have about COVID cases is aggregated data at, say, like the county level or state level. And so we tend to need more information than we have readily available. And getting access to detailed individual level data generally takes a long time and a lot of resources. And right now, most of the resources are rightfully being committed to more immediate treatment efforts or other more immediate prevention efforts. And so that's one limitation that we have to deal with. Another issue is that we need sufficient exposure contrast. So exposure contrast essentially means that we can see a difference in that exists because we have some people who are exposed to high levels of whatever pollutant we're interested in, and some people who are exposed to low levels, and some people who are exposed to sort of medium levels of the pollutant. And if you don't have people exposed to different levels, even if there is a true effect, you won't see it because you're not seeing the differences in the patterns that lead to the outcome. So therefore, there aren't going to be differences in the outcome. And so that's a problem. And one of the issues that we've seen, particularly in some of the initial papers that were published in this area, were that they just didn't have sufficient exposure contrast. Like they didn't study COVID over a long enough period of time because it hadn't existed for a long enough period of time to really, see lots of different environmental conditions over time and space. And so around now, we're starting to see papers that are coming out that actually can start assessing these questions with better exposure contrast, but we really did need to see a few months of the pandemic to understand these issues. And so that's been a challenge. And then another really important thing I want to bring up is that to do this kind of environmental epidemiological work for COVID, we really have to think carefully about what statistics and what mathematical models that we choose to use. There's a lot of different approaches, and the right approach depends a lot on what question you're asking, what data you have available. We need to have unbiased data on exposures, outcomes, and other factors that can modify or confound the relationship between exposures and outcomes. And right now, it's really hard to get that kind of detailed, unbiased data. So for example, with exposures, if we're trying to assess people's exposure to air pollution, we're concerned a little bit about urban-rural differences. We know that we tend to more accurately estimate people's exposures to air pollution in urban areas because we have more monitoring in urban areas than we do in rural areas. So that can be a problem, and that can lead to bias in our estimates. Additionally, we have to think about what outcome metrics we want to use. We've seen with COVID that, if you look at any of the public dashboards, there's 5 zillion different metrics that people are reporting, and sometimes it can be really hard to sift through all those different ones and know which ones are the most relevant for what kinds of questions. And if you look at the daily trends, you'll see that, for example, case counts change a lot day to day, and the day of the week matters a lot. So you can average over several days and lose some of the temporal resolution, or you can explicitly account for day or week, but you have to do something, right? You can't just take some of these numbers at face value and think that that's going to provide an accurate estimate of what's happening in the population. And then I just wanted to say that I'm bringing up all these limitations and challenges in the research, not to suggest that the research that's being done isn't high quality. I mean, I think people are trying to do the best that they can, and that's, and there's definitely is some variable quality in the research that is published, but I think it's important that when you're looking at the research and you're trying to evaluate it for yourself, that you're looking to see a forthright discussion of limitations. You should see the authors discuss the sources of error, the types of uncertainty. Authors should be stating their assumptions very explicitly and whenever possible, quantifying the impact of their assumptions. We try to do this with our research. In fact, that's sort of the premise of what we're writing our papers on, is that, for example, we're trying to understand how the unit of aggregation for the different environmental metrics, for example, at the zip code or the county level, quantitatively affects the results, and trying to disentangle just that spatial scale of exposure estimates and how that ends up mattering for our health estimates. We're also trying to explicitly test how simulated sets of individual data based on aggregated COVID case information may represent or not actual individual level data. And the nice thing is that through some of the work that my co-panelist Tom Stopka will talk about, we have access to really good individual level data that's nationally representative. So we're actually able to do some of these quantitative bias analyses. We're also trying to estimate a range of environmental conditions so that we can build better predictive models and account more explicitly for potential urban-rural differences in exposure error. And this is really important. We really want to make sure that we're thinking about how to equitably estimate health effects so that there can be also an equitable implementation of pandemic control efforts. And so this work is definitely still in the early stages. It's moving fast, but it's really exciting, and it's hopefully will help answer some of these important questions. And I welcome your ideas and hope to continue the discussion as we learn more.
Yeah, all right, thank you very much. And then moving on to Tom, so a similar question. Can you please tell us about your work in regards to the misinformation and why you've chosen to engage in this work?
Sure, thanks Alejandro. So as an infectious disease epidemiologist, I'm keen on mixed methods research. So what does that mean? That includes like qualitative in-depth interviews and focus groups. That includes surveys and secondary analysis of existing surveillance data. That includes GIS, or mapping of data, mapping of risk and spatial epidemiology, understanding where there are hotspots and cold spots, and laboratory techniques to understand what's happening within communities. And so the work that I've been involved with that relates to COVID is one, the study that Laura is leading, that is looking at the relationships in environmental exposures and COVID outcomes. What I bring to the team that's perhaps unique is that ability to map data and look at spatial relationships between where temperatures, humidity, pollution might be higher or lower, and what implications that might have for progression of disease and mortality, right, outcomes. And so I'm really excited about that study moving forward and collaborating with a multidisciplinary team, folks with lots of different backgrounds. I'm also involved in a study funded by the NIH, which focuses on administration of medication for people with opioid use disorder within houses of corrections in Massachusetts. And while we didn't set out to study COVID in this study, it's come to our front door, right? As it's come to our homes in our neighborhoods. That is that houses of corrections, penitentiaries are extremely high risk for COVID outbreaks. And so we've been talking closely with our collaborators within the jails to learn about how things have changed, right? There have been a number of inmates, low risk inmates who have been released to try to decrease risk for infection. There have been less people coming into prisons because arrest rates have changed, because there have been different priorities of late, and an understanding of the risk that comes with incarceration. And so we've taken a look at how kind of medication for opioid use disorder was increasing and how it has decreased over time, counts and rates, because less people are in the houses of corrections. We've also been trying to understand what it means for corrections officials and public health and medical staff within corrections facilities. Another study that Laura and I are collaborating on with Drs. Peter Levine and Jen Allen and Deborah is looking at equity in health, wealth, and civic engagement. And we completed a survey, nationally representative survey, in late May, early June, which included a number of questions around COVID. And we're just starting to explore, analyze, and send out press releases that you'll soon see focused on inequities in COVID experiences. That is, who are folks who are most likely to report being tested for COVID? Who are most likely to present that their family members have been tested? And we've seen some interesting disparities along educational levels, race, ethnicity, as well as political affiliation. And so we're trying to tease that apart in terms of testing, in terms of willingness to social distance and quarantine, in terms of ability to quarantine, on using sick time from your employer. So that's an area that, fortunately, timing-wise, we were able to incorporate into our survey. I also work on a number of studies focused on substance use disorder, infectious disease, and overdose. And so some of our research has been delayed in terms of our hepatitis C mobile telemedicine-based interventions that are supposed to be happening in rural Vermont and New Hampshire, because we want to go in the field when it's safe for participants and for staff. But that has implications in terms of how we can start the intervention and the trial, the clinical trial.
And thank you everyone for all the host of information that you sent. So just moving on to like the second round of questions. So we're running a bit on the clock. So if these questions could be answered in like a couple sentences, that'd be great. So I guess we can start with like the same order again. So Abby, the people want to know. So a host of information is being shared surrounding the pandemic, and it brings to mind kind of like, what's the best way to go about finding good quality information? So essentially, what's the best way to sift through the huge volume of information, such as source, levels of uncertainty, the data source, etc.?
Yeah, so I would say that I actually use Twitter a lot for this. I know it really depends who you follow, but there are some really great, former administration officials or infectious disease doctors or epidemiologists who are helpful. There are also a few things like there's a source called Brief 19, which provides weekly updates of literature. There's some really great YouTube videos by Eric Meyerowitz, and I'm just blanking the name of the other guy, but if you look for Eric Meyerowitz, that should be fine, which have an hour to hour and a half long review of the important clinical and scientific advances, and those come out once every 2 weeks on YouTube. So those are some of the sort of summary resources that I go to. There's also a good literature summary at Boston Children's Hospital. University of Washington has really good updates on vaccines. So those have been putting together good literature reviews. In addition to that, if you're interested in the scientific literature, it's helpful to subscribe to table of contents from journals that you're interested in. So I've subscribed to like Nature, Science Cell, Nature Immunology reviews, stuff like that. And so that way I can get a sense of what the literature is like. So that's good for just accumulating stuff. And then I also have some keywords on Google Scholar that I've put on to try to look for COVID pathogenesis. And also that will collate many different resources together. But I would say following good people on Twitter and these key review resources are helpful. And then of course, we're trying to do some of that work in putting together important advances on our curriculum website as well. So you can check that.
All right, thank you.
But yeah, in general, to look at whether something is well done, I would say if they only have a press release, that's usually not great. So you want to see that there's an actual paper that's been published. In the world of COVID, there's been much more reliance on preprints than there had been previously. So just the fact that there's only a preprint doesn't necessarily mean it's not good quality, but it's important to read the paper well. So I would say similar to what Dr. Corlin and Dr. Stopka said, especially Dr. Corlin, it's important to see that they have pretty rigorous methods and that they are able to discuss and not too overreaching in their discussion. So they're able to discuss the the caveats to their findings, which always exist, but if they're trying to basically oversell what they're saying, that's not great. So yeah, and then I would look for a big enough study sample as well. So making sure that it's not a study on like 4 people or something like that, that it has enough power to really reach a reasonable conclusion.
Yes, thank you. And then moving on with the next question for Laura. Again, very quickly. So some public health officials and epidemiologists see opportunities to link the current prevention response for COVID and the long-term response to climate change. So could you talk about these responses, how they might relate in a couple sentences, really short?
Sure. So 2 big areas, but in both cases, we need sustained collective action. COVID has been seen as very risky. It's a very immediate threat. It's new. People sort of see how it affects them or people that they love directly. So it has a lot of these factors that increase people's perceptions of risk. And in this case, rightfully so. Whereas climate change, people tend to perceive as more of a longer term risk, maybe not as directly applicable. And, people have heard a lot about it, so they don't necessarily have this urgency in their action. But in reality, we really do need to have the same sense of urgency and the same understanding that climate change is immediately pressing and directly harmful to us and to people who we care a lot about. And so I think that using some of the power that we've seen with COVID for climate change would be a very positive thing. And we can actually link the efforts too. I mean, some of the COVID recovery response we can use for green energy and climate initiatives and things like that. And there's some precedent there in previous economic recovery periods where we can use, we can use positive climate and environmental justice actions to improve the COVID economic problems as well.
Yeah. All right. Thank you. And so I think I can pass this on to, wait, Deborah, should I pass it on to you or one final question? Oh, I can't. You're muted. You're muted.
The question. Oh, sorry. Sorry about that. Yeah, so I think it would be great to ask Tom the question, and then we'll move to the next panel.
Yeah. So Tom, final question. So some public health officials, again with the parallels, are seeing parallels between the current pandemic and the long-term response to HIV and AIDS. So could you expand upon these parallels? And this is just going back to a lot of the politicization of public health events.
Yeah, and it goes beyond that really. And I have a few slides that I'll share with you. But we've learned a lot from the AIDS epidemic over the last 40 years, and we see lots of parallels with COVID-19 in terms of the response. And some of the echoes of the AIDS pandemic that we're seeing currently in the COVID pandemic are the baffling, deadly new illnesses that dominate public health and private conversations. Fear and ignorance sometimes compromising and trumping reason and science. And then a national response that's really created a vacuum that's quickly filled by rumors and misinformation. And both introduce themselves in very dramatic fashion. Both are transmitted by somebody who oftentimes is infected but doesn't even know it, right? Doesn't show symptoms. So who's infected? Am I next? Is a concern. The numbers are just frightening, right? In terms of the millions and millions of people infected and have died from AIDS. And the growing numbers rapidly for COVID. But it's brought about a new framework in terms of prevention approaches. That is safer sex and safer drug use patterns within substance using populations. And for today, for COVID, social distancing and shelter in place, something we probably didn't think about much until the last few months. And a harm reduction approach is something that has been effectively used in the AIDS pandemic, and that I believe can be used well for COVID. And that is that abstinence from, say, sex or abstinence in terms of social interaction is probably impossible. We're human beings. We like to interact with one another. And so getting to a new normal, we have to think about practicing safer social distancing, really remembering, as Tom Frieden likes to say, wearing the 3 W's, wearing a mask, washing your hands, watching your distance. But some colleagues at Harvard have put together a really nice infographic focused on harm reduction as it relates to COVID. On the y-axis, you see the risk of transmission. On the x-axis, you see activities that we partake in on the home front. beginning to go outdoors, gathering in groups, and the highest risk, gathering indoors. Remember, the epidemic is not going away, and it may revisit our door in huge numbers in the coming weeks and months, given what's happening in the rest of the country. So there are lots of different harm reduction approaches that we can keep in mind. And Where's Waldo helps us to remember that he shouldn't be in a crowd. He should be separated. That's really us changing our lives and our approaches. So just wanted to emphasize this harm reduction approach, what we've learned from the AIDS pandemic, and how we can apply these lessons learned to the COVID pandemic.
Yeah, thank you very much. And before passing it on to Deborah, I do want to thank you all for joining this panel discussion, and also just thank you for all the amazing work you're doing in response to the global pandemic. So.
Okay. And Alejandro, thank you so much for your wonderful moderating, and thank you so much to all of the panelists for sharing your wisdom and your insights, your expertise. We're really, really grateful. So thank you. And then to all of the participants, we want to move right to the second panel. We have a very rich second panel with 4 panelists, and just want to make sure that we have ample time for that panel. So we're going to skip the time for pause and the reflection exercise, but invite you to try the 4-4-8, taking a breath now on your own, while I bring up slides to introduce the next panel. And also I invite you to write in the chat some words of appreciation for the panelists who we just heard from. So from Dr. Abby Schiff and Dr. Laura Corlin and Dr. Tom Stopka. So words of appreciation in the chat would be great if you are so moved to do that. And right now I will switch in a moment to, I just have to bring them up. The slides. But you know what? They're not showing up right away. So I'm going to just move right into introducing our next panelist. So for our next panel, we have Dr. Lisa Gualtieri, and who is a Tufts faculty, and she'll talk a little bit about herself in the introduction. We also have Dr. Tariana Little joining us, and she is a recent graduate, just earned her PhD at the Harvard Chan School of Public Health. We also have Jenna Sherman, who is a Tufts 2017 grad, and she was in the Community Health and Peace and Justice Studies majors. And then we have Dr. Josephine Wolff, who is a professor at the Fletcher School of Law and Diplomacy. And so each of our panelists will give a short overview. And I want to also introduce Aram Lee, who is a panelist. She is a recent Tufts grad, class of 2020. And Aram, we're so glad that you're here and that you've agreed to moderate. Thank you so much to all of the panelists. So Aram, you can pick it up now.
Thank you so much, Deborah, and thank you to all the panelists for being with us today. I would love if you could start out if each of you could share your pronouns and a fun fact about yourself, as well as tell us a little bit about your work and why you chose to engage in this line of work. So Dr. Gualtieri, if we could start with you.
Hi, so first let me thank you for the invitation to be here. And I think Deborah has put on just an amazing set of speakers. It was really fun listening to some of my colleagues speaking in the session preceding this. And so I'm Lisa Gualtieri. I use she, hers. I am an associate professor in the Department of Public Health at Tufts University School of Medicine. And a lot of my teaching and research focuses on different aspects of digital health. And so my real interest in COVID-19 is how do people seek and receive information about this. And a lot of what I've been looking at is how social media can be used in this way, following on for what Abby was talking about. And I just kind of take a broader view looking at this, and also looking at it in the context of how people's information-seeking behavior has changed because of both the pandemic and also because of the less availability for traditional medical appointments.
Great, thank you so much. Dr. Little, I would love to hear from you next.
Hi, good morning, everyone. My name is Tariana Little, pronouns she, her, hers. A fun fact is that my former mentor, Tufts mentor, Lisa, and I are Words with Friends playmates. And so we have a friendly competition every single day on our phone with Scrabble. I have a brief PowerPoint showing the work that I do and sort of, detailing the narrative. So I would love to be able to share that. So in terms of my time on this panel, I want to focus on community perspectives. And my work encompasses public health, communications, and social entrepreneurship, which is using business for social good. And through my company Envision, we help forward-thinking organizations use the framework of social impact storytelling to achieve their goals. And it's rooted in 3 pillars: real people, real stories, centering those closest to the matter, and conveying impact. And some of our clients range from universities to startups to government institutions, or larger, hospitals and the like. And we have a strong focus on social justice, health, education, etc. So in light of COVID-19 misinformation, some questions that I ask myself and I challenge all of us to consider is, what are the dominant narratives? What is talked about a lot and what's less talked about? What are the real world impacts on people most affected by an issue? So in terms of this pandemic, who's most affected and what are their experiences? What are their challenges? Who's being excluded from traditional media? Who is the one that's saying most of the important information? And who are the stories, the voices that are on the margins? And what's work that communities are doing on the grounds locally? So those are how I approach COVID-19 misinformation or any other issues when it comes to issues that have a national stage and a very local impact as well. In my company, we have something called Community Portraits, which is our own original series. And this is where I've been able to do COVID-19 independent work, where we've been able to amplify voices of community members and their experiences and use our tools, use what we have at our disposal to be able to help communities surface experiences, viewpoints that we don't typically see nationally or on TV. So we did the Stay Hopeful series, which was a feature of 8 different people, from frontline workers to students, talking about their visions and their experiences in terms of the COVID-19 epidemic, from naming systems of oppression and saying, how can we dismantle them, to challenging what a new normal means in a capitalist society where essential workers, for example, are not the most paid or not the most protected, right? So really surfacing critical conversations that we may not be seeing in traditional media, from reflecting, to the world and saying it's cleaned up the world in so many ways, less pollution, less use of all these materials, to thinking about how can we show up better for our world from a best-selling author. Sorry. So also a 6th grade artist, right? So do we have children talking about what the pandemic has been like for them? So having a child talk about how he's struggling to find toilet paper, for example, at one point, to make his puppets, to make his art. That's not something we think about when we think about materials that we don't have access to. How is it affecting, children or other members of our society that depend on these things in a very different way than what we originally think? And then, a restaurant owner and how that's affected her business model, but how she's been using that, her business, to help healthcare workers and feed them during a time of crisis, all the way to people that are activated, whether it's in their school running for student government to help other students, to an ER doctor who's, runs a nonprofit that registers people to vote while they're in the waiting room, because he sees the connection between voting and political power, and then the healthcare and other social policies that affect us. And so I'll leave it here. And I'll resume this PowerPoint once we get to other questions.
Great, thank you so much. Jenna, if we could hear from you next.
Absolutely. Thanks so much, Aram. And I first just want to really express my gratitude for the invitation and to be able to be here on a panel with such brilliant and wonderful colleagues and mentors of mine. It feels like some sort of like funny academic reunion for me. Tariana was one of my TAs. Laura was a mentor of mine at Tufts in undergrad. Dr. Wolff I'm connected to through the work I've been engaged in for the past 3 years. So just want to say what a gift it is to be able to be here and to learn from and with all of you. As Aram said, my name is Jenna Sherman. I use the pronouns she, her, and hers. And a fun fact about me that I quite rarely share, but I feel is apropos in this conversation, is that a video I was in high school turned into a viral meme. And again, it's quite embarrassing, so I try not to highlight that one, but it felt fitting for today. So my background is focused on reproductive justice and digital health, and also the intersection between those two areas. I think it's in the chat right now, but for the past 3 years, I've been working as a senior project coordinator at the Berkman Klein Center for Internet and Society at Harvard Law School, focused on AI policy with an emphasis on AI ethics and bias and discrimination. And that work was not at all connected to what I was studying in undergrad, at least not directly, but it did, I think, connect quite indirectly to the subjects that I was deeply involved in at Tufts related to peace and justice studies and community health, and thinking about social justice and community impact, and also trying to break down some of the barriers that exist in the tech world when it comes to social justice. And that's what really got me interested in thinking about the intersection between tech and health. And it's shifted a little bit more towards the misinformation world. So the 3 areas that I'm most involved in right now with regards to the with regards to the pandemic academically are one, my work with a group called Medan that has a database responding in real time to questions regarding COVID-19 for journalists and fact-checking orgs. The second is a group that I helped to create with some wonderful colleagues of mine at the Harvard School of Public Health, where I'm pursuing my MPH, called Students Against COVID. It actually touches a bit on some of the work that Abby was speaking to in the first panel. And then the third is a research project that I'm involved in on studying the health and well-being of infants who are born to incarcerated women and their caregivers. And because we're studying that right now in this current moment, we would be remiss not to try and understand how COVID-19 is impacting folks who are impacted by incarceration. So those are the 3 different projects that I'm involved in right now related to the pandemic. I'll focus on the first 2 because those are the most directly connected to misinfo. So I'm just gonna share my screen really quickly, if okay, to give you a sense of these 2 different projects. The first I mentioned is with an organization, let's see if this works, called, sorry, I'm just pulling it up, called Medan, and they're focused on understanding and navigating journalism in the digital realm. And a significant part of what they do is mitigating misinformation. So we have a team of public health experts who are fed questions by fact-checking orgs, journalists, newsrooms, and other NGOs in order to provide really empirical, but also like quick turnaround information, not necessarily to do the fact checking ourselves, but to provide the context that can help others kind of like draw their own conclusions, if you will. So here's just an example of some of the information that we're addressing, and we usually try and keep it pretty concise and then have more background and context if folks are able and interested in reading more, and you can see all the tags from where it comes from. And the goal of this work is really to is to help journalists stay connected to what's going on in the science world. I alluded to this earlier, but there really is an ivory tower that often prevents information from being really like circulatable and from getting to the public in a fashion that is trustworthy and accessible. So this is one of the projects. And then the second, which is also very much related to that theme, is the Students Against COVID work. And this is a very similar kind of endeavor substantively, which is that we're trying to collect the latest information in real time, often stemming from much of the sources that, again, Abby touched on in the first panel, and creating them into digestible graphics intended for social media. And this work is geared at youth audiences online primarily, but really is intended for anybody who is a user and might be interested in having ownership in a way and empowerment over COVID information. Another really big qualm that I see in the misinfo world is that it can be really patronizing and a sort of like othering effect when saying like, you know, we know the information and you are wrong. And our goal here is to, again, like provide the resources to users themselves to be able to share and then serve as arbiters of information themselves. And we also have a few kind of like supplementary approaches to this work. Also, one which includes creating templates for individuals to copy and paste when they see a certain myth, to be able to do their own corrective work online. And this has actually been shown to be really effective online and online spaces, because even if a person spreading a myth isn't impacted by it and doesn't change their mind, the reach that social media has in terms of who's seeing it actually has a really significant impact. And so by equipping the public, it really does go a long way in terms of creating a healthier online information ecosystem. So I'll stop sharing and then just quickly say why I was drawn to this work. So I touched on some of it, but again, just really, I'm interested in destigmatizing health misinformation. I feel like it often becomes like a very classed issue. It can become a very race issue. And I feel like that's unfair and is incorrect, actually. Anybody can be prone to misinfo. I'm sure we all have myths that we have believed or do believe. I could name a whole list right now that I grew up with. And if you're watching, Mom, I'm sure you have a few that you are aware of as well. And again, empowering individuals to be their own arbiters of information. There's such an erosion of trust right now in the media and online spaces, that doing that kind of like bottom up information quality work is that much more crucial. Also de-siloing tech and public health. I, in undergrad, did not have any really, it was less of a lack of interest and more just a lack of understanding of how I might fit into the tech world. And now knowing that humanities perspective is so crucial and actually is actually quite necessary for tech work, has significantly changed, I mean, my course of work, but also just my perspective and how I engage in day-to-day life. And then finally, overarching all of these is the fact that this is really inequity is an issue of social justice, also especially with regards to the COVID-19 pandemic. The fact that so many folks don't care, especially wealthier white folks don't care, is not a mistake. You can really see that a lot of the, sorry, I'm in New York City and it's a little bit loud, that a lot of the perspectives on practicing social distancing and other practices shifted when it became clear from the data that Black and poorer folks were more affected. So also this is really an information quality issue that's directly related to social justice. And being somebody who grew up low income and in rural Alabama, it's just that much more important to me to do the work and make sure that this isn't just a top-down approach, but is really bottom-up, rooted in social justice. So I'll pause there and I can speak more to any of this in the questions down the line.
Great, thank you so much, Jenna. And last but not least, Dr. Wolff.
Thank you so much. I'm Josephine Wolff. I'm an assistant professor of cybersecurity policy at the Fletcher School at Tufts. And as you can maybe tell from my title, I'm really wildly out of my depth here on a panel with people who know so much about public health and medicine, both topics that I am completely ignorant of. What I work on is really sort of understanding security and privacy threats posed by technology, in particular computers and the internet. And so my interest in this area is really around sort of the ways that we've seen it exacerbate, highlight certain types of problems that we've known for a long time, existed in our internet technologies, but are kind of intersecting in interesting ways with different technological issues. And I'll talk about three topics I've looked at very quickly. One is really around network capacity and thinking about what happens when everybody starts working from home, when schools all over the world shift to remote learning, and everybody is relying on their home internet access, assuming they even have home internet access, to get access to things like work and education. And again, we've sort of had for a long time a sense that there are very significant disparities between the kinds of infrastructure that people in different places have for internet connection and the capacity of those networks. But we're really seeing quite starkly right now that a lot of the initiatives that have been put in place, for instance, bringing internet access to a library in a rural region where there's not good access, are not adequate, are not giving people the capability to get access to services that they need right now. And that's a sort of very important thing to be thinking about in the context of a much larger debate about the internet that's been going on for more than a decade now, of is this sort of a privilege or is this a really fundamental utility that everybody needs access to? And 10 years ago, when policymakers started talking about this in different countries, there was, I think, a strong sense by many of them that this is kind of a luxury good, that, you know, if you want to watch stupid cat videos or the viral video of Jenna from high school or whatever else, that's not something that, you know, the government needs to be involved in making sure you have access to the way they're involved in making sure you have access to water or heat or electricity. And one of the things that I think this moment is reshaping in the tech policy community is a little bit of our sense that actually this is a fairly fundamental utility now, that if you don't have internet right now, you don't have access to school. You may not have access to work. You may not have access to all of these other things. So that's one area I'm interested in, is sort of what's happening on the networks as we're seeing this rise in the use of residential internet connections. Another thing I've been interested in are some of the contact tracing systems that are being used in different countries to keep track of who people are near, where they go. The two main uses of that are often around trying to enforce quarantines and see if people are violating them, and also to see who people have been close enough to possibly have transmitted COVID to and alert them. And there have been a lot of sort of really interesting stories where we see some of the less privacy protecting systems actually backfire. South Korea is an example of this, where there's a fairly open system in the sense that they will kind of tell everybody somebody who was this age, wearing this, who works at this office, was just diagnosed and was at this nightclub last night. And if you were there, you should be on alert. And people have actually started lying about sort of who they are and their information when they go to places because they're worried about this exposure. So thinking about some of those systems and what solutions there are for making sure that as we try to do contact tracing, we're also trying to do it in a privacy protecting way insofar as possible. And then finally, on the disinformation front, I would just highlight there's a really interesting intersection happening right now around kind of political and election disinformation, which we've known about for several years and which we knew was going to be a big issue going into the 2020 presidential election, and the misinformation around coronavirus and medical information that everybody else on this panel and the previous panel is much more qualified than I to speak to. And part of what I'm interested in is sort of what are the social media platforms, Facebooks, the Twitters, Googles, willing to do by way of taking down misinformation when they're looking at political issues versus when they're looking at public health issues, and what happens when we actually see those two kind of intersecting, when we see, for instance, Russian trolls posting on Twitter that nobody should go vote in the primaries because the primaries have all been moved due to coronavirus. And so there's been a lot of sort of complicated questions around that, as well as questions about what governments like the Chinese government, the Russian government are doing in order to restrict information about the pandemic that they view as harmful, either internally or externally. And so there's sort of been a lot of interesting tech stories on that front as well. And I want to stop there and turn it back to you, Aram, for questions and discussion.
Great, thank you so much. This is all really important information, especially as I'm at home and I'm in Mississippi learning about all of the misinformation here. So thank you so much all for sharing. And actually, if we could circle back to Dr. Gualtieri, I believe you have some slides to share. Oh, you're muted. Just...
Okay, thank you. So I have the honor of sort of rounding out the panel, and I feel like everybody has such incredible insights about how our world is changing. And so I look at a lot of the data that's out there that, we have the impression that things have changed in everybody's lives, but it's fascinating to see specifically what people are doing differently. And obviously, one of the ways that we've all been dramatically affected is in the area of education. I also look at telehealth. I look at a wide variety of types of communication that people are engaged in and what specifically they're communicating about, and looking at people's use of news. So it's not surprising that searching for COVID-19 updates is one of the most common activities that people are doing today. In addition, they're also searching for things like banana bread or where can I find yeast? And there have been these fascinating changes in people's search patterns overall. But going back to health, it is wonderful that sources like the CDC and the World Health Organization have really stepped up here and have been far more visible than they've typically been in any previous health situation. The CDC has been every place and really trying very hard to use attractive graphics and appeal to multiple health literacy levels. The World Health Organization has been prominent on platforms like TikTok, which they certainly weren't on before, and really understanding that there are more effective ways of reaching people and better platforms to use to reach people than have traditionally been done before. So I find it fascinating to sort of follow this and to also look at what is and isn't effective that they're doing, and also what kind of engagement are they receiving. But one of the really scary statistics is that half of people are finding that the information, it's difficult to determine what's true and what isn't true. The good news here is that people are aware that of fake news thanks to the huge amount of publicity, but still, what do people do about this? And there's just such a huge amount of misinformation and false information out there. And the ways that people are searching, because people are home more, people are online more, has also changed, which means that they're exposed to more misinformation as well. So there has been an increase in positivity. There's also been a lot more critical analysis of how the pandemic is being managed. And there's been an increase in topics completely unrelated to the pandemic, like banana bread. So what I look at are really three areas: health information, like the examples I was showing, the CDC's information. I find humor really interesting to look at as well, because it's saying a lot about how people are feeling about something. And then finally, the commentary, conspiracy theories, and abundant misinformation that's out there. So there's videos that have just millions of views, thousands of comments, and it's really fascinating to see which are the ones that are trending. Like I said, there's been a really good use of information to reach people and to make it easier for them to understand what they can do and what to be fearful of. I mentioned humor. the humor has really evolved from the Corona beer jokes to things like this, which was trending on Facebook. And that's saying something about people's attitudes and how people are feeling about their daily lives. And, the kind of barbed humor like this. But people are really fearful of the future, and people are concerned about their economic stability, about so many factors in their lives. And fear is something that does play out very quickly and very prominently on social media. So one example was something that I saw on Facebook, which was really this very ageist view. And it's really scary when you see people talking about things like that and influencing people. I don't know if any of you saw the Plandemic movie, but that was, kind of wildly popular for something that had very little credibility to it. As there were changes in state or regional rules, you could see things like this happening, and people were very commonly posting and commenting on this. And a lot of it was very, very critical. So what does this mean for you? I think that we can all fight erroneous information with facts and with empathy. And on the empathy point, I just want to give a shout out to one of the initiatives that Tufts did, their communication team called Tufts Together on Instagram. And these Instagram stories are students talking about what's been hardest, has there been a silver lining, and what are you doing to stay safe? And I'm really honored that this came from something that I was doing with one of my classes that I felt was really successful at reaching them, because everybody's lives have been changed. And even if you can say there are other people that are having a worse time of it, we still have to acknowledge that it's been painful for many people. It's been difficult. It's been a struggle. And even to ask people, what are you doing to stay safe? And giving them the opportunity to share that kind of information, I think is very, very powerful. So let me turn it back over to Aram and for the questions and discussion.
Yeah, so we have some collected questions for each of the panelists. And actually, Dr. Gualtieri, there is a question for you. So as people delay medical appointments, are they more likely to search for information online and therefore be exposed to mixed quality information?
Yeah, I believe that people are delaying doctor's appointments, delaying traditional medical care, and then relying more on symptom checkers, on searches. And this comes back to the issue of what is reliable. So people know the CDC, the NIH, the Mayo Clinic, but there's a huge amount of information out there that is erroneous. And if you're viewing this information, and this is in the absence of being able to check in with your care team and find out, does this apply to me? Is this accurate? That can lead to real problems. So there have been some recent reports talking about, maybe one of the silver linings in people not seeking medical care has been that so much medical care is actually unnecessary. But the problem is that there's this middle ground, and you really don't want people to be making major medical decisions like not taking a medication that's been prescribed in the absence of clinical care.
And I imagine too, there are also financial concerns as well, as people are losing their jobs, struggling to think about reaching out for medical care if they don't have insurance and things like that as well. It's definitely an issue.
Absolutely. And so there are always many, many factors influencing the decisions that people make. And, and sometimes they're not valid as well. And but you don't necessarily have an easy way of sort of checking in and finding out what is it going to cost, or doing the cost benefit analysis.
Right. Thank you so much. That's actually a good segue into maybe thinking about more community voices. So for Dr. Little, the question is, in the midst of a pandemic and reliance on all of these authority voices, what is the role of highlighting community voices, especially in your work?
Thank you. I'm gonna try sharing my screen again so I can talk about this. So in particular, I wanna address this question through the example of the COVID-19 crisis in Chelsea, Massachusetts. Chelsea is home to 40,000 residents. It's 2.5 square miles, so it's pretty tiny, and it's the second most dense city in Massachusetts after Somerville. The population is predominantly immigrant, predominantly non-English speaking, specifically Spanish speaking. And Chelsea is sort of the warehouse, the storehouse for a lot of the food that's distributed throughout the region, as well as the airport right next door, and so and other sources of pollution for the community. So as you can imagine, there is a lot of environmental and social justice issues facing this community. So the national narrative and also the statewide narrative is very negative, right? In the height of of the pandemic, Chelsea had the highest infection rate in the state. It was 6 times the state average, and so there is this very negative portrayal of Chelsea. Yes, there is an emergency here, and we have to attend to that. But how I view it is this the whole story? So when I think about COVID-19 misinformation or any type of misinformation, for me, it's not about what is untrue that's being said. It's also what's incomplete about what is being said. So, in late May, Attorney General Healy published a brief on the environmental pollution and how that's contributing to the health crisis that we see in communities of color, including Chelsea. So linking policies and practices and action, what Jenna was talking about, social inequities and how that shows up in this pandemic. So COVID-19, the rates that Chelsea has been experiencing, it's not in isolation. It's due to other structural factors that have made this community and others like them especially vulnerable to be hit by this crisis. And then you have, op-eds written by community voices, leaders of community organizations in Chelsea talking about what is happening on the grounds, right? They're, the work they've been doing to champion environmental justice, and then the impact of these systemic issues on their lives. So we had the opportunity to collaborate with, one of the leading organizations in Chelsea, Green Roots, which is an environmental justice organization. And we were able to kind of, flip a narrative. You have all these negative statistics, negative stories. Well, what's the community doing? And so we created a video for them where we see Chelsea residents harnessing the collective power to fight against the crisis. So it's not just this narrative of we're needy, come help us, but also we have a lot of talent and resources within our community. We have a lot of strong community ties, a lot of trust, a lot of relationships with residents, and we're uniquely positioned to support them and to be, vessels of support and information for them. And so the video was to support the One Chelsea Fund, which was a fund created by the United Way of Massachusetts Bay in collaboration with other local organizations in Chelsea. And together we were able to raise over $1 million in the May debut alone. And so it's over $1 million at this point. But that is the power of community. That's when you go from who are the traditional authority voices and what are they saying to there's other voices that are just as authority figures in a different way. They're the experts of their own lives. They have a different viewpoint of the issue, in many ways more valid viewpoint of the issue. So let's amplify that voice. And with that, thank you.
Yeah, I think one of the most uplifting things that I've seen throughout this entire pandemic is people coming together in ways that they didn't have before, or amplifying those connections that they already had established before the pandemic happened. So I want to thank you, Dr. Little, for sharing that, because I think it's so important to think about the ways that we can come together and sort of fight back in the ways that we can, in the limited ways that we can. And now sort of thinking about AIs, for Jenna, how does the use of AI intersect with the pandemic, and what are the ethical implications of that?
Thanks so much, Aram. I just want to quickly make sure this goes until 25, right? Okay, 12:30. Okay, so I will still try and keep this as pithy as possible, but I wanted to know how fast. So it's an excellent question. I'm really happy it's being asked, and I'm really excited to speak to it. The first quick caveat I'll say is that there are undoubtedly significant pros and benefits to the use of AI in the healthcare realm for identifying trends, tracking misinformation. It's actually one of the projects that I'm working on. Working towards more personalized medicine. I think there are really significant pros. I'm going to focus today on more of the risks, mostly again because I'm focused on thinking about bias and discrimination and how disproportionate impacts from emerging technologies play out. And what we've seen is that it's thunderstorming here. Is that most of the pros of AI and other emerging technologies benefit those who already have more privilege, and most of the cons disadvantage those who are less privileged. So that's why I'm focusing on the cons. There are three main buckets that I like to think of with regards to risk of AI. There could be a million different framings for this. This is just one that I find helpful. The first one is promotion of misinformation. This one is more inadvertent. The other two I'll mention are more directly related to the intentional use of AI to improve healthcare. Misinformation often comes as more of an incidental effect of using AI in the digital realm, which I'll get to in a minute. The second is bias and discrimination, which I've mentioned. And then the third is more general surveillance. And Dr. Wolff touched on this a bit, and I'm sure we'll do a much better job at speaking to it than I do. So I'll just quickly touch on those first two. Because I know we are very short on time, and I just have two very quick slides. So the first is thinking about this incidental outcome of health misinformation online. Let's see, present. How do I present? Oh, it's being blocked by this. So this was yesterday. This is a screen grab from yesterday. I truly just searched vaccine on Amazon, and the first two results that came up are books that lean towards vaccine hesitancy. And I highlight this because it shows how much power that whoever is most involved in the digital realm has on algorithms and how they are prone to manipulation and ultimately misinformation in many cases. And then I also searched COVID-19. And the first and highest search result that came up was this book, Unreported Truths About COVID-19 and Lockdowns, which has been criticized by public health experts as having substandard information. So I just wanted to quickly touch on how algorithms, when playing out online, this is just one really small microcosm of how this happens, can promote misinformation without intervention, but even with a human in the loop. In this case, actually, Amazon had decided not to publish this and then went back after criticism. So even with humans in the loop, it just shows where the power is and how misinformation can be promoted. Then with regards to bias and discrimination, this gets at what Laura Corlin was saying in the first panel about biased data, but of course that was more about statistical methods, and this is more specific to AI-based technology. So this is just an example of racial bias playing out in an algorithm used in hospitals. And in assigning a risk score to patients regarding chronic care. So you can see over here, on the x-axis, these numbers indicate the actual burden of chronic disease. So if we look at a 3, so all patients here are at the same level of disease. The Black patients, the purple line, are assigned about a risk score of 80, and the white patients are assigned about a 94, 95. And this is because healthcare cost was being used as a proxy for actual healthcare burden. And these are the kinds of biases and difficulties that play out and that concern me with regards to the application of AI in healthcare. And we're already seeing this play out with COVID-19. A few different healthcare AI tech companies have made funding deals specific to the COVID-19 crisis. And there's one really notable system created by Epic, which, as you may know, is a really huge vendor of electronic healthcare records. And that's predicting which COVID patients may become critically ill. And although there was like an internal audit, there's not enough data to have been like really sufficiently externally audited, but it's in use across hundreds of hospitals anyway. So this isn't to say that they should not be used, but that we need to be much more critical about how they're implemented, about thinking intentionally about race, about class, about who might be left out of these data sets and who might be most impacted. So I will stop there, unless there be another thunderclap, and turn it over to Aram and then Dr. Wolff.
Great, that's actually a perfect segue into Dr. Wolff's question, which is, how does technology both contribute to disinformation, and how can we try to use it and combat disinformation?
Well, it's a big question, and I've got about 2 minutes to answer it, so I'm not going to do it justice at all. But I think that what you've even just seen from Jenna is sort of the beginning of that answer around, we know that social media platforms, we know that technology makes it really easy to really rapidly share disinformation at scale. It also makes it very easy to detect some of that disinformation and not make it impossible to access, but make it pretty hard. Right, so one of my co-panelists mentioned the Plandemic video. I was speaking with a class a couple weeks ago about that video, and many of them that had done a reading about it had then sort of been curious to try and go watch it and found it quite difficult. And not impossible, but you have to really search around. It's not something that's easy to stumble upon. And I would say, to sort of perhaps try to end on a note of hope here, that one of the things that's been interesting to watch as compared to the ways that social media platforms have really struggled with thinking about whether they can take down and label political disinformation, or whether that's going to sort of make them into the center of a partisan fight, is there's been more consensus, not uniform, but certainly more by those companies, that medical and scientific misinformation is something they really need to act on. We've seen Facebook be much more aggressive about trying to take down sort of false COVID claims than they have been about really any other kind of disinformation. I would say it's certainly not perfect. It's certainly controversial. It's certainly still very flawed, especially where it starts to intersect with political issues where they really want to seem neutral. But I do think you see some of the tech platforms looking at content like Plandemic and really making a pretty concentrated effort to say this is not something we want on our platform. This is not something that we see doing anybody any good, in a way that it's really been hard to rally them around disinformation in the past in other areas. And I'm going to stop there, because what I've learned about teaching on Zoom is the most important thing is that you end very promptly, or everybody just falls off the call. Thank you all so much. This was really interesting.
I just want to thank all the panelists for being here and taking the time to go through all of how to dispel misinformation. And yeah, I'm going to turn it off to Deborah or Peter.
Great. Thank you so much. I'm Peter Levine from Tisch College, and if we haven't met online before. And I just want to say thank you, first of all, to Aram for an amazing job of moderating, very nicely done. And also to Lisa, Jenna, Josephine, Tariana. That was super useful. I hope everybody takes a quick look at the questions that are in the Q&A. They got answered to some extent, but they were really good questions, so it's worth just looking there. There are discussion groups now from 12:30 to 1 for those who are interested. There's a different link, so this Zoom will close and you'll find yourself in a different discussion group if you want to join. So check out, I guess, Canvas would be the place to go if you don't have that Zoom link right handy. Those are optional for everybody, but they are a chance to process what we've learned and discuss some of these issues. And I'll just say two other things. There'll be a survey. There's a survey after every week, please, about the week, about how it went. Please fill it out, because we really do use it to think about how to adjust for next time. And we're really grateful for those responses. And then also, if you've signed up for the certificate of participation, you get a brief reflection questionnaire, which is more about your own thoughts on the substance. And so you need to fill that out as well if you want to get the certificate. And so with that, I'll just thank everybody, also including Deborah Donahue-Keegan, who organizes all these things, and close us out for the day. And see you next week. Oh, and that's the last thing. I knew there was one other thing. So next week, we're back for a session on civic identity, engagement, and leadership for social impact in these times, in these challenging times. So that's a little bit of a pivot. Today was a lot about science, information. next week is more about yourself as a civic actor. So come back, and we'll see you then.